here. My name is Chris Dorval. I'm a licensed independent clinical social worker and drug and alcohol counselor. And today for our presentation, we're going to be focusing primarily on adverse childhood experiences, specifically the ACE study and its implications to practice. Throughout the presentation today, I'm going to try and pause to ask questions. If you have any questions, don't hesitate to put them in the chat box. But if I'm prompting for questions, feel free to unmute yourself. I think it would be better for us to have a discussion than to try and type, especially with the limited amount of time here. So I'm going to jump right into it. First and foremost, the ACE study, or Adverse Childhood Experiences study, was done in Kaiser Permanente, actually in a suburb of San Diego, by Kaiser Permanente Health between 1995 and 1997. The principal investigators on the study were two physicians, Vincent Folletti and Robert Anda, and they initially began the study as a way to look at obesity and the implications and costs of obesity. And so what they had started the study, began putting people through a number of weight loss programs, which all seemed to work really well. We're reducing, comorbidities that exist with obesity, like hypertension, diabetes, and a whole host of other things. But what they found was that many of their patients that had done well on the weight loss program subsequently then regained weight shortly after discontinuing treatment at the hospital. And so just on a hunch or intuition or clinical judgment, both Folletti and Anda wanted to look at the impact of childhood experiences on the individuals. And what they found was that there was a direct correlation between adverse childhood experiences and obesity and a whole bunch of other chronic health conditions. So they began asking a series of questions which were known as the adverse childhood experiences questions. So the initial study was done from 95 to 97 with 17,000 participants. It was a longitudinal study. With a pretty good sample size. Each participant completed a confidential survey containing questions about childhood maltreatment and family dysfunction, which we'll look at these items in a second, and then items detailing their current health status and behaviors. This information was then combined with the results of their physical exam for the baseline data. So these were the 10 questions that they asked. These were the adverse childhood experiences questions as they ask. And so it's important to remember these and think about these. One, perhaps for yourself, but two, perhaps for the students and people that you work with on a daily basis. So before the age of 18, did you ever experience recurrent and severe emotional abuse? Yes or no? Recurrent and severe physical abuse? Yes or no? Contact sexual abuse, physical neglect, emotional neglect. Before the age of 18, did you grow up in a household with an alcoholic or drug-using parent, a family member being imprisoned, a mentally ill, chronically depressed, or institutionalized family member, or your mother being treated violently? And finally, before the age of 18, did you grow up in a home where both biological parents were not present? And so they were self-report questions that were asked each one of the participants. And a yes answer would be a positive score of 1, a no answer would be a 0, and then they tally up the scores at the end to kind of determine your ACE score, if you will. And so the data that preceded it really started to unravel and really started to tell the story that we're hoping to learn a little bit more about today. So when we look at the data, this is what we found, is that even 50 years after the experiences of these adverse childhood experiences, these experiences had transformed into psychological, social, and organic diseases, as well as, to name a few: smoking, alcohol addiction, IV drug use, and obesity. And that was found initially off the original study, and then replicated again in 2003. The other thing to keep in mind, and this is one of the more, now remember, in this study, it's a correlational study. So what they were able to determine is that adverse childhood experiences were correlated to, but not necessarily the cause of ailments, these other experiences that individuals were having. In addition to that, they also found that if a child has more than 6 yes answers, their risk of becoming an IV drug user increased by 4,600% compared with the child of 0. So again, correlational, right? It's highly related to. But when you have a 4,600% correlation, you're looking about as close as you can in a correlational study to causality. In addition to this the other things that we looked at here: smoking, alcoholism, injection of legal drugs, and obesity, depression, suicide and anxiety-related disorders were also indicated as being having a strong linear relationship between adverse childhood experiences and those diagnoses as well. So initially, the ACE study was done to determine the impact of these experiences and how they continued to manifest in later in life. Now, one thing to note about this study is that this study was done. Now, this is the end of the research article, right? This study was done in a suburb of San Diego. Any of you ever visit the suburbs of San Diego? No, because none of you can afford to, just like myself, right? So we're talking about a higher socioeconomic status population here, even despite the fact that it's 17,000 participants. We're also talking about, this study was done through primary care interventions at Kaiser Permanente Health. So we're talking about a suburban community outside of San Diego in Southern California of people that regularly visit their primary care physician. Does that sound like your average client population, average student population? Probably not. So do you think issues like poverty, less resources or less access to healthcare would even further exacerbate these conditions of some of the people that you work with on a daily basis? Absolutely, right? So one of the things that we have to keep in mind here is that not only has this study been replicated multiple times, I think 5 or 6 times at least that I know of, and shown to have the same results. It's been done in other communities such as inner city Baltimore and Chicago, and the results are actually pretty similar, which is surprising. I would expect that they'd be much worse. However, the results are actually pretty similar. And the reason why, and we're going to talk about it today, is that the impact of trauma and the pervasiveness of trauma is really understood by the individual. So if you live in inner city Baltimore and you're living in poverty and you've been abused and neglected and suffered, with family members being incarcerated and all these other things, that is the worst experience you know. If you live in suburban San Diego and your parents had a terrible divorce and your mom was, abusing painkillers and wine, and you lost your first, car because that is the worst thing you know. So trauma is really subjective. And so again, one of the things that I always try to remember and try to keep in mind is that trauma, the worst story any of our students, any of our patients, any of our clients will ever hear is their own, because they lived it, it affected them and the people they care about. And it's really subjective. So we want to keep in mind that despite all economic, financial, and social disparities or healthcare disparities, trauma sees none of that. It's still going to affect you the same way. And it's still going to affect people of all, of any background. And so, I've heard people say before, oh, well, I work in this district, that's not really a problem. I'm like, really? Because a lot of my experience has been working with people all across the socioeconomic status, and it doesn't matter where you are. I always see these incidences existing in people's lives. Money, resources don't change things because, again, it's subjective depending upon the person's experiences themselves. So I also want to talk about another study that was done just outside of Boston by Joe Spinazzola, who's a physician at the Trauma Resource Institute, which I believe is in Brookline. And so he had done a study in 2014 looking at the impact of childhood maltreatment and neglect in comparison to childhood physical and sexual abuse. And what he found was that childhood maltreatment and neglect, children who exhibited maltreatment exhibited either equal or greater baseline problems, symptoms, and disorder compared with children who had experienced physical or sexual abuse on most indicators. So what his research is saying, in short terms, and again, I don't want to ever say that one is better than the other, but that children are almost better off being physically and or sexually abused than being maltreated and neglected. Now, again, not advocating that we sexually or physically abuse children. It's just that oftentimes we expect when we hear someone's story that, oh, I was physically abused, oh, I was emotionally abused, we respond in a way that we think, oh, that's terrible and I must help you. There's resources available and we focus on that incident. But we oftentimes miss the underlying, more subtle, more covert traumas like now maltreatment and neglect. And in this case, he operationalized that term maltreatment and neglect as invalidating caregivers, parents who were non-responsive, didn't show affection within the home. So we're not talking about parents that were torturous and brutal. We're talking about parents that were just flat, non-reactive, maybe not there. We're talking about parents who may have experienced some type of incarceration or mental or physical health illness themselves, right? And maybe they did love their children and did everything they could, but maybe they were experiencing a chronic medical condition that pulled them away from the ability to be present and active and emotional for their child. We're talking about the parents that didn't show up for the softball games, that didn't show up for the baseball games, you know, those kids that sat there with heartbreak. And oftentimes we know it's sad, but we don't respond to them the same way because we're like, well, at least you weren't sexually abused. Well, you weren't physically abused. And I'm sure none of us think that or say that in our head, but in the back of our mind, we're like, well, it's not as bad as this. So why these results are the way they are when we look at it from a physiological or a neuroscience standpoint is that the impact of traumatic stress, right? Stress that causes these traumatic wounds from a very short time, from an event like a physical or sexual abuse trauma, has a very high acute spike in stress hormone, right? Has a very big shot up of cortisol and other glucocorticoids in our and stress hormone in our body that helps us respond and then come back down from stress. So the high effect of that affects the way that the brain and body interact, the way that we store memory, the way that we process memory. But when we have these persistent traumas, right? Like growing up in poverty, growing up being bullied, being neglected or maltreated by your parents, the level of acuity or the level of height that stress hormone is released isn't as high, but the duration is so much longer, right? We're talking about months, weeks, sometimes years, maybe even a decade, right? If you're talking about someone being bullied in school, right? The cumulative effect of that stress, of that hormone, that physiological stress changes the way that the brain responds, changes the way that we react, right? And so oftentimes these kids get looked at or misdiagnosed. And one of the main comorbidities of trauma like this is something like ADHD, right? The kid's having a tough time paying attention in school. He's having a tough time paying attention at home. Doesn't really, you know, well, wouldn't you if you were picked on everywhere you went? Wouldn't you if you didn't know where your next meal was coming from, or if your dad was actually going to come home this time, or if he wasn't going to come home, or if your mom was going to be home tonight when you got home, or are you going to have to lock up the house yourself? I mean, really hard to pay attention. Now, diagnostically, if you find the criteria for attention deficit hyperactivity disorder, it might look like it, but the etiology of it, what's driving this, what's causing this, is the stress that these children are experiencing. And if we don't see the major event that we often look at, like the physical or sexual abuse or the car accident or these major event traumas, we oftentimes overlook the impact that that cumulative stress is having from these more subtle or covert traumas. And we don't focus necessarily on responding and healing the trauma. We focus on, you know, treating the symptom, which is the inability to pay attention. And oftentimes we medicate and stimulate and overstimulate and over-medicate some of these kids where the root cause of their problem has very little to do with this, you know, lack of being able to pay attention. It's the lack of resources to be able to commit attention to the places that they find themselves in. I'm going to quickly define trauma. You know, trauma is one of these words that gets used a lot. It's a buzzword in the behavioral health community for sure. And I know that it is. It's moving through, you know, the world. I remember watching a TV show the other day and they were talking about trauma and psychological trauma. And I was like, wow, that's interesting, right? 20 years ago, it wasn't something you really heard that much about. One of the best definitions of trauma that I've ever heard is this one, right? Is that trauma occurs when an external threat overwhelms a person's internal and external positive coping skills. So this definition comes from Bessel van der Kolk, who's a world-renowned expert psychiatrist on treating trauma. And some of you may be familiar with his book or his article, How the Body Keeps the Score. But he defines trauma as that external threat, right? Something outside of us that overwhelms a person's internal and external positive coping skills, right? Our ability to cope with things in a positive and healthy way. Now, oftentimes we see coping skills develop in unhealthy ways, right? Like aggression, violence, abuse, substance use, eating disorders, self-injurious behavior, right? Those are all coping skills. The problem is they're not very healthy. Same thing with isolation, depression, dissociation, right? These are all ways of, social withdrawing. These are all ways of coping with an external threat. However, they're not very healthy for human beings. You know, maybe the best definition, maybe my favorite definition of trauma is to look at where the word comes from itself, right? The word trauma comes from the Greek word, which means wound, right? So if you go to a trauma unit on a hospital, you're going to see wounds all over the place. At the end of the day, when we're talking about trauma, specifically from the perspective that we look at it as clinicians or educators or family members, we're talking primarily about psychological trauma. We're talking about wounds to that person's intrapsychic self, right? The way that they look at themselves, the way that they look at the world, the way that they, and those wounds, unfortunately, don't heal as quickly as physical wounds, right? There is no ointment, there is no antibiotic, there is no, short basis intervention. A lot of times these deep-seated emotional and psychological wounds take much longer to heal. And sometimes are overlooked and looked at as other things, especially when we talk about things like being aggressive, being angry, being upset, being violent, right? It's hard to develop that same level of compassion for that individual when they tell you they hate you and they want to get out of your office and throw a chair at you. But at the same time, that individual is doing the best they can with the coping skills that have worked for them to keep themselves healthy, safe in situations that are less than desirable in their life. And so it makes it so much more challenging to respond in a compassionate and empathic and loving way to a person or a child that's experiencing those, that's giving us those symptoms. So jumping back into the PowerPoint here. So how does someone get traumatized, right? We need to broaden our understanding of how people are traumatized. Now, there can be direct personal experience of an event, right? That involves a threat and death or actual injury or threat to someone, someone's physical integrity. It could be witnessing an event, right? One that involves death, injury, or the threat of physical integrity to someone else, even if you're not familiar with that individual. Or it could be learning about an unexpected death, serious harm, or threat or injury experienced by a family member and other close associates. So you don't even have to see it. You don't even have to, it doesn't even have to happen to you. It could just be hearing about it. Could you imagine being a child and hearing that your parents passed away? Now, you didn't see it, you weren't there, but what an experience that might be. Or how about your parent was incarcerated, or both parents were incarcerated, or a parent was in a serious car accident and might not survive. I mean, when we think about the developing brain, children are they're dependent on their parents. They're dependent on their parents to meet their needs, especially at younger ages. So when these needs are threatened due to an injury or an insult to a parent, the child is now fearing for its own safety, its own life, its own ability to have its needs met. And they may not be processing this cognitively because they may not have the ability to do so. They may not be thinking at that level, but their mind is certainly making those connections, and their body, again, is storing that information. Like, now we need to protect ourselves. Now we need to do for ourselves. And it can really jeopardize the safety and integrity and interrupt brain development as this child gets older and older. So we talk about stress disorders, traumatic stress disorders, specifically post-traumatic stress disorder, but any traumatic stress related disorder. We're talking about the individual's response to abuse, violence, or some other neglect, or some other overwhelmingly negative experience, right? So again, it's a very subjective experience. Two children can grow up in the same household and witness and experience the same things, and one may develop these symptoms, one may not. It really depends on their individual resilience, and sometimes there's innate personality characteristics that help or hinder a person from developing these symptoms. And it's then the subsequent set of adaptive behaviors. You'll see that I have the root word mal here, mal coming from the Latin meaning bad. There's nothing bad about an adaptation, right? And so as working with individuals, we have to remember there's nothing bad about an adaptation, even if it is less than lovable. These adaptive behaviors are ways that these people have learned to survive in some less than desirable circumstances early on in life. So things that we can do to help respond and establish an approach to working with individuals who've experienced trauma is to establish and abide by these core principles of trauma-informed care. So first and foremost, and probably, if we were going to pick one to be the most important, the first principle we want to be aware of is the idea of safety. That throughout the organization, throughout the school, that staff and the people that they serve feel physically and psychologically safe. Now, given the current circumstances we find ourselves in right now, it's impossible, and really at any point, it's impossible to guarantee perfect safety or 100% safety, but we want to do everything we can to improve safety on any level possible, right? And so obviously we're all taking extra precautions to be physically and virally, I guess, if you will, safe. in the world that we live in right now. But we also want to protect emotional and psychological safety as well. And these can be really small micro level interventions, right? Like asking permission before asking questions, asking permission before closing the door, inviting the person, inviting the student to share and or not share as much information as they feel comfortable with. Maybe shutting people down from over disclosing certain information if it can't be closed up in a nice, healthy way before ending a session. You know, one of the things that I've had to learn to do, particularly in the work that I do, is sometimes hold people back and do it in a way that they're not feeling like their information is too much, but that it may be too much too soon. All right. And I'll give you an example. I've in my practice, I have people that come to me all the time. Oh, I want to work on my trauma. I want to work on my trauma. And I'm like, okay, well, tell me what's going on in your life right now. And they're like, well, I'm in a horrible living situation with an abusive, partner. And, I'm not sure if I'm going to be living there, if I'm going to be living somewhere else. And I really want to get into it. And so I need to be able to get into it so I can figure it, get my head straight and figure it out. And I'm like, you're no way near ready to start talking to me about this right now. And they're like, why? I really want to, I really got to resolve this. And I'm like, you're absolutely right. You do. But right now is not the time. You don't have enough resources. You don't have enough safety and stability. And it's important that we protect that person, because sometimes opening too much up or oversharing information can actually re-traumatize the individual. One of the things that we have to be aware of, and we'll talk a little bit more about this afternoon, but is in the process of working with people who've experienced trauma, it's inevitable that we may trigger them. What we need to do, however, and that's okay, triggering is okay. We by triggering people and then helping de-escalate them, we can open their distress tolerance. What we need to be careful with is not re-traumatizing people, where we don't take a past negative experience and redo it for them all over again, thereby, exacerbating an already difficult situation. So safety is a very important thing. And probably where we spend the majority of our time, and where all roads and these core principles lead back to. There's also trustworthiness and transparency, right? Are we doing everything we can to be as trustworthy and as transparent with the people that we're working with as we can? Reaffirming confidentiality, reaffirming and really explaining it in a way that someone at their age level can understand. And letting them know that there are limits to it and what those limits are. And if you say certain things, that this could potentially be a problem, right? And really making sure that we're paying attention to that and affirming that. And this can be really tiny little interventions too. And I talk about this all the time is, if we have a class, or if we have a meeting and it's scheduled at a certain time, right, to begin at 8:15 a.m., that the meeting starts at 8:15 a.m. And I know, we live in the real world where things happen, and sometimes you start at 8:17, sometimes you start at 8:20. But when we do that, not to dismiss the violation of trust that was given to us. And I know it seems so minor, but with individuals who've experienced, particularly emotional and physical neglect and abuse, that is such a violation that you told me 8:15 and now it's 8:20. And, it's just like what happened in my whole life. People are always lying to me. And so when we do come in at 8:17, 8:20 for a meeting that's supposed to start at 8:15, that we don't just dismiss it, that we actually make an amends for it, right? And say, hey, I'm sorry, we ran late. I know it's 8:20, and acknowledge it, right? That acknowledgement and that ownership of the situation really builds that sense of trustworthiness, transparency, and gives us an opportunity. And this is just one example of many that could happen in the course of the work that we do. In addition to trustworthiness and transparency, we have collaboration and mutuality, right? That the person that we're working with knows that there's a true partnering, and that we're doing everything we can to level the playing field. In many of our interactions with the children that we work with, we have to recognize that there's an inherent power dynamic, right? And that's okay, and it's understood, right? But in the process of connecting and relating, anything we can do to level the playing field is really going to actually help make that person feel a little bit more safe, a little bit more like they have, they're a person, and really, develop that genuine and authentic commitment to their own work, their own growth that we're hoping to get. We also want to look towards empowerment, right? That we're recognizing strengths and validating them and helping develop new skills as one of the things that we can do, particularly with, with kids, is give them the opportunity to grow. Right. I see a lot of times one of the things that happens when we start to look at this work, the people that we work with from the lens of people who've been wounded or people who've been traumatized, is that we overcompensate by giving them more. Oh, let me do that for you. Oh, let me help you here, rather than empowering to do for themselves. Right. So it's really important that we recognize their strength and help develop the skills that they need to develop, but we don't actually overcompensate for the fact that they've been victims or they've been abused or maltreated or neglected in the past. And the next principle that we want to focus on is voice and choice, right? That we're strengthening their and their family's opportunity, if the family situation is a healthy and supportive one, opportunity to recognize their experience is unique and requires an individualized approach. Want them to kind of be the leaders of what we're hoping to accomplish with them and their own personal growth. It's we really want them to have that sense of autonomy in the relationship as much as we can. Obviously, within every organization, every school, every place we're at, there's certain rules that need to be abided by. There are certain non-negotiables. But whenever there's an opportunity to negotiate or an opportunity to have a voice, we want to make sure that we can provide it to this person. So they feel like that they have some, for lack of a better term, skin in the game of their own growth and change. We also want to establish a sense of mutual responsibility. And I think that this is a paradigm shift from a traditional perspective where we typically look at developing accountability. So again, accountability is a one-way street, right? It's only it only goes up, right? You're only accountable to an authority or a figure greater than oneself. With mutual responsibility, we're leveling the playing field, right? We're not looking at this power dynamic as being power over, right? It's a more relational dynamic where it's power with, right? Where we're all working collaboratively towards the same goal. Instead of assigning a student a task or assigning them a consequence, that we look at this situation that resulted in either the task or the consequence and find out how we, being as their resource or their support, can also help take some responsibility in helping them achieve this goal or helping them, get to the point where they're at. And so, for example, if a student asks, for help with, dealing with a struggle in a relationship, instead of saying, well, here's some information, why don't you take a look at this? Saying, I will, my responsibility in this will be to help you find the resources and information that can help guide you in that direction. Your responsibility in this situation, what I need you to do, or what your task will be to actually read it. And then we come back together and we talk about this together. That way they would recognize and understand that that you're both mutually taking some responsibility for this individual's growth and healing. And finally, compassion, right? We want to look at compassion as a way of understanding their life, their thoughts, their feelings, and really allowing us to honor the suffering and the experiences that they've had, not necessarily changing it and not necessarily, helping reshape the way that they look at it, but sometimes just allowing them to just share their information with you and bear witness to the story and making space for them to have those really difficult emotions and being present with them when they do it.
For the empowerment, just to combine it with the identification of the adaptive skills that they acquired, which are now showing up as maladaptive skills, bringing them to counseling, of course, but just identifying those adaptive skills as something that is impressive because they did that and it really helped them survive and they came up with it. And whatever that skill was, you don't want to get rid of it completely, but you want to kind of find out what was it fulfilling, what need were you trying to get, and how can we do that in a positive way?
Absolutely. So oftentimes with things like that, again, as I had mentioned earlier, a lot of my work and a lot of my practices in the world of substance use. So pretty much everybody that has a history of trauma, we know, where their substance use began, right? Or what it was trying to do in terms of self-medicating. And so typically the approach with substance use is, well, this is bad and this is going to kill you. But, you know, the approach that I typically take is, you know, what purpose was this serving? Like, what did you like about it, right? Like, give me the pros and cons, right? There was something about this that kept you doing it for this long. And as a matter of fact, it sounds like you were pretty resourceful in being able to do this and thinking about the ways that you were able to sustain your addiction and maybe hide it from people, or maybe keep a job or still show up for school or even pass courses. Like, how did you do that, right? And so rather than just shaming them out of their maladaptive behaviors, really supporting them, but saying, perhaps there's a healthier alternative, right? Because it seems like that skill that you're using is no longer working all that well for you because this has happened, or whatever consequence or whatever thing is that brought them into your office. So it's, again, you know, it's about not really taking a negative approach to any of their less than lovable or less than adaptive behaviors, but really kind of honoring them for where they came from, right? You know, I'm a firm believer that with very few exceptions, pretty much every behavior we see makes sense in the context in which it arrived, right? So like using substances, being violent, right? Like yelling at your family members, yelling at authority figures, right? That made sense at some point until it didn't, right? And maybe that's all you know, right? And so I understand why you did it, but you can't, right? And so remember, one of the things that I always have to remind myself when it comes to compassion is that compassion isn't collusion. Right. And I think a lot of times, particularly in situations where, you know, if you're in a school and there are rules and there are expectations, that we feel like if we align with the student on their negative behavior and support it, even in a small way, that we're somehow giving the wrong message, right? That we're colluding with them for their negative behavior, or we're enabling them to continue in that pattern of negative behavior. And the reality is we're not, right? We can still draw the line and say, I understand why you did what you did. You can't do it again. Let's think of healthier alternatives that will keep you from doing this again to meet the need that was meeting when you were doing it, right? Or began to meet when you were doing it in the past. There was another question that came into me through the chat on suggestions, particularly for educators who may not be in a clinical position but want to cultivate safety. So one of the things that I always see, particularly in classroom settings, is there's always an expectation, and I see it for myself, you know, teaching, you know, at a college level, that if a student isn't talking, that they're not learning, right? And so there's the tendency to like, let me call on this student. And again, I can understand it to a certain extent if you're trying to challenge that student to maybe step outside their comfort zone, but we also have to recognize and respect that different, you know, people have different personality characteristics, and that perhaps there are certain strengths and weaknesses that can't necessarily be overcome and maybe shouldn't be called upon. So I'm thinking really specifically of an example, you know, and some of you, you know, have probably seen this in your own educational career. The teacher used to call on a student that's not a good reader to get them better at reading in public. Right. And so they'd be like, come on, Sean, you read. And Sean's terrified right now. He's already stuttering before he even opened his mouth. Right. And then he has to suffer through 10 minutes of trying to get through a page and a half. And the teacher's like, great, you're participating. You know, we're challenging you. That may not be the right time, because those 10 minutes are now resulting in hours of psychological torture for this poor kid. So things like that, right? Like asking preferences for students, you know, being more open and informed, right? You know, we always talk, especially in the world of behavioral health, about being culturally competent, but we don't look all the time at, you know, and typically when we're talking about culture, we're talking about ethnicity and we're talking about gender and we're talking about race, but we don't always look at the culture of students, right? Like what it's like to be a 15-year-old, right? Or a 15-year-old in this school system, right? And so really helping to come from a place of humility, right? Like, tell me what will work for you, right? And again, acknowledging that, you know, that as the educator, that you're going to be the authority and you're going to have some education and background in how to help assist. But we also, again, and it goes back to that core principle, using voice and choice, allowing each student to have some level of autonomy and authority about how they can best be taught. Right? What works best for them. And then when appropriate, challenging them to step outside of that comfort zone, but not forcing them outside of that comfort zone, if that makes sense.
You just highlighted, it goes back to the safety part of it. For kids I'm thinking in a group, I used to do a therapeutic group, so kids who have been through trauma, and just for them to feel safe. Part of it is not calling on them, because being put on the spot, and just the predictability of being in a group. It's in setting up a structure where you do know what to expect, and you start on time and things like that. I was just gonna just piggyback on what you were saying, and how the value of that, and how the small things that we think are small that go a long way and make you feel safe in a space where you could be yourself, and you don't have to feel like you're participating in the way that everybody else is. You might contribute in a different way. So really checking with kids, if it's in a group setting, really checking with them to see what's okay with them in terms of what makes you feel safe. I think it's a good way to address that part.
No, absolutely. And I think one of the benefits, if there are any benefits, right, to the technological educational world that we now find ourselves in, where people are doing remote learning and things like that, is it's given us some new avenues for some of the more challenging academic, tasks that we've been able to complete. And specifically what I'm thinking is, remember the class project that we all have to do at some point every year in every class? We have to stand in front of the class and talk about it. Well, one of the things that we've been doing, at least at a college level, and I know some high schools have been doing, is rather than standing you in front of the entire class, you can do a video at home and record it and then upload it. Right? So there's not 25 people standing around. Maybe you can do it in your own home when you're a little bit more comfortable, right? You're on your home turf, right? And you're not like thinking about lunch or thinking about afterwards. And so doing that class project and having it recorded and uploaded. Now, again, it takes a little bit of technological savvy. However, it turns out that the majority of our kids are way better at it than most of us. So they can teach us on how to do this. But I've seen it on a college level where instead of having people do, the class presentation in front of the class, that this semester we've had them upload videos, and the people who are usually really quiet and reserved have had some really interesting things, because guess what? If they don't want to look at you or they don't want you to look at them, they just do this and they talk behind the slides, and they don't have to worry about anybody seeing their face or seeing their facial expression. So it's a really effective way of using technology in a way to kind of advance and create a sense of safety beyond just physical safety, but really creating that emotional and psychological safety as well.
I think it's really interesting that you bring that up, because I work with students all the time who hate having to do these presentations, and it's like really hard to argue with the teacher. They're super uncomfortable. They have such anxiety about this, and it's like, well, that's the requirement. Like that's 20% of the grade.
Yeah, and I get it. At the same time, but and again, there's a time where it's okay to push people outside of their comfort zone, right? That's where growth begins. With people who have had histories and experiences with trauma, so it's better to be more invitational and really kind of help them feel like they have some sense of autonomy, and offering an alternative solution, right? There shouldn't be black and white. Well, you either present it in front of the class or you get a 0, right? There should be, or there's an alternative option, and this is the alternative option. I think we need to look at something that's less pervasive, and really expand the way that we allow people to put themselves out there, because not everybody is going to be comfortable putting themselves out there in those circumstances. Even today, right? Like public speaking is one of the world's biggest phobias, right? The most common phobias. Nobody really enjoys public speaking. People that do are usually sick. I enjoy it, and I recognize that, so I can own it. But most people really don't like it, right? And I understand why. Now let's add in, additional factors like, abuse or neglect going on at home, bullying happening at school, limited resources, both financially and socially. Is that kid going to ever feel safe to stand up in front of the class? So now forcing that kid is just further re-traumatizing that child in a way that's only going to make it worse, right? You're taking a bad situation and making it worse for the sake of what? Proving a point that everybody can stand in front of the class and talk? Well, yeah, but can they do it without having to hate themselves or hate their life? And that's the real challenge. So jumping back into the PowerPoint here, So a lot of the research that's been done on the impact of trauma has helped understand that trauma resides as much in the body as it does in the brain. And even where it resides in the brain, it's typically at our lower level systems, right? Our non-cognitive systems, the part of our brain that's not responsible for thinking and rational decision making, which we also have to recognize isn't fully developed in most of our kids, right? The brain doesn't fully develop. This prefrontal cortex or this neocortex over here doesn't develop until about 25 years old. So most of what we see in teenage behavior is this limbic system behavior, right? This fight, flight, freeze, feel, and fornicate type of behavior that we see in teenagers is only exacerbated by the hormonal changes and the lack of reason and insight developed in the neocortex. And then further down, we have this R complex brain, right? Our instinctual survival behaviors. When the brain is working well, we know that all three of these systems are working together collaboratively to, help run this, this machine that we call a body. But when a person is feeling stressed or overwhelmed, whether from an acute event or something that's going on chronically at home, this neocortex is going to be functioning at an even lower level. And when triggered or when activated, when their trauma is either triggered or activated, this neocortex and the actual neuronal activity, right, will actually start to shut down. If we look at an MRI or a PET scan of a brain of somebody under stress, as particularly a teenager, we're going to see that there's very little activity going on in that neocortex, and that limbic system part of their brain is like running on all cylinders. You're going to see a lot of light there. So we have to remember that asking them to use insight and use reason isn't always a way of them responding, because they may not actually have the physiological ability to activate that part of their brain. So that's where using body-based interventions can work really well. One of the things that I recommend, particularly in school, is having kids up and moving around as often as possible, taking time for practice of things like deep breathing or meditation or even like a standing yoga in classroom. I know is hugely effective because it gives them an opportunity to come back in their body, to regulate their body. And again, it's a soothing and responsive behavior. There's multiple evidence-based articles on the impact of using meditation prior to test taking that has improved test scores exponentially in kids. And because a lot of kids experience, test related anxiety, and I'm sure there's some of us in here that do. And if we take that extra couple of minutes to just kind of re-regulate and ground ourselves, we can be so much more effective, both cognitively and socially, really. So using that is another major skill. So we also need to understand the process of trauma, right? That we have this experience that overwhelms our body's ability to cope. We have these fight, flight, or freeze responses, which result in these sensitized changes to our nervous system and our brain and our body. We also have this psychological or physical distress symptoms of triggers or memories or sensations that happen as a result of it. And then finally, we have the emotional and physical responses, right? We have retreat or internalized type behaviors like isolation, dissociation, depression, and anxiety. We also have externalized harmful behavior, right? Like aggression, violence, rage, or threats. And then on the inside, we have these self-harming behaviors like substance use, eating disorders, deliberate self-harm, and suicidal actions. So again, it's important for us to recognize that all of these bottom emotional and physical responses, from isolation to violence, from substance use to depression, from suicidal ideation to dissociation, are all symptoms of a traumatic related response. So one of the things that I always stress, right, in doing these trainings is that we want to start to look at trauma as a universal precaution, right? To be trauma informed is really a universal precaution. The same way we're all wearing masks and washing our hands 200,000 times a day and using hand sanitizer every time we see or walk by one, right? We should be thinking about trauma as the same way, right? That we should take universal precautions and expect that people should have a history of abuse or trauma, and not that they're the exception. That many of the difficult students that we have, like the ones that have been bounced from classroom to classroom, from school to school, have unresolved or unaddressed traumatic stress in their life, even if they haven't disclosed it. And that we as educators, as resources, as supports for them, can do a better job at understanding how and why they got traumatized and responding in a way that's informed by their experiences. And really what we're hoping to do with becoming more trauma informed is to have this paradigm shift where we move from what is wrong with you to what happened to you, right? Whenever I see some type of antisocial like behavior in a young adult or a kid, I know something happened, right? This stuff doesn't exist in a vacuum. This kid wasn't born bad, right? We're all born, you know, in my opinion anyway, with some innate personality characteristics, but primarily we're a tabula rasa, right? We're a blank slate, but some things can happen that shape and turn us into who we are. Right. And for those kids that are exhibiting really difficult or challenging behavior, I always have to say, what happened to this person where they think that this is an okay behavior to respond with? So I want to save the last couple of minutes here to answer any questions.
I did have a question, actually. Sure. You just said trauma informed is a universal precaution, right?
It should be.
Yeah, is there any like, because I know there's going to be, you know, educators or teachers and things like that watching this. So any sort of digestible material or a good place to start for them to really sort of start to learn and soak that in? Because I know we're pretty clinical here, and a lot of us, you know, seek that out, because I know we're all kind of psych nerds. But teachers aren't always, you know, there for that. So, but they are oftentimes the safest person to some of these kids. So, or, you know, the main authority figure. So any suggestions there?
So one of the things that I wanted to that I suggest watching, right, is there's a video that I would recommend that really helps explain the impact of attachment and attunement. And a lot of times that is when we talk about these more subtle or covert maltreatment and neglect traumas. That's what we're looking at, is this attachment-based trauma where people are experiencing the inability to connect with other people. So this video is actually the still face experiment. Some of you are probably familiar with it from Psych 101, right? Understanding how babies are attached and attuned to their parents. And this video really puts into perspective some things, you know, that we see happening in our older kids, right? You know, who lose their ability to self-regulate when somebody's not paying attention to them, or when they feel like their needs aren't getting met. In this video, you're going to see it happen in a 9-month-old child after seconds of being, you know, neglected, right? Of seconds of the parent not responding to them. Now, imagine what that would be like cumulatively for over years as the brain develops. And so this video really puts into perspective a lot of the less than desirable behavior many teachers are probably experiencing in classrooms with some of their more difficult students, or the really withdrawn behavior, right? Because when in this video, you'll see as the parent responds to the child, there's a connection, there's a healing, and they come back and they can go back to it. And children, you know, thankfully are resilient. But sometimes that doesn't happen. Sometimes those connections aren't restored. And we get children who are extremely despondent, shut down, flat, and withdrawn. They don't seem to care about anything, right? And it's because that connection to understanding who they are as a self never really happened, right? Never really came together. And so, you know, understanding a little bit more about attachment and attunement, and Dr. Tronick does a really great job in this, is another great way. I think, again, as an educator, to use more creative and up and moving body-based exercises for the kids, you know, getting them moving around class, talking with each other, working in small subgroups. You know, as clinicians, particularly those of us who've done group work in the past, one of the best clinical interventions that I can think of in terms of working with a large population is to do subgroups, right? Let's break up into our groups of 2s and 3s, because people are more active, they're more engaged, right? They're more likely to take risks in a group with 2 or 3 people than they would in a room with 22, right? So doing that same thing in an educating process, right? Putting people in small subgroups, having them learn to work together, right? And also making time for independent work. But when we're doing large group work, right, because it allows them to take risks and gives them an opportunity to feel that sense of safety and that sense of security that they wouldn't necessarily get in a classroom with 15 or 20 other kids.
I think about that. Remember that old film, The Breakfast Club?
Yeah.
The kids are all together and they're all sort of different socioeconomic statuses and different life experiences, and they're sharing what terrible things their families have done to them. And they asked the last girl, what awful thing did your family do to you? And she said, they ignore me. And the filmmaker saves it for last. And it just reminded me of that, and that it's something we forget a lot, that, kids are neglected. They're not.
The invalidation.
Yeah.
Yeah.
So thanks for pointing that out. I think that's important.